Hello and welcome to Inside Ophthalmology. I am Dr. Amrit, welcoming you to another lecture. Today we are going to be talking about the allergic conjunctivitis, right from the basics to advanced stuff. So this video is going to be useful both for undergraduate and for the postgraduates. So now, what exactly is meant by the allergic conjunctivitis? This term is self-explanatory. People have all sorts of allergies. Now the question is, what are allergens? Now these can be things like pollens, dust, animal fur, or even certain perfumes that can actually trigger the allergies. When your body comes into contact with these allergens, your immune system thinks that they are harmful, even though they are not, and it kind of overreacts. Now, this overreaction causes various symptoms like redness, itchiness, watery eyes, and sometimes even swelling. This is known as allergic conjunctivitis. Now, depending on how your body reacts, the allergy can happen quickly or take a bit longer to show up. Now, this happens because of two types of immune responses. We have a quick response, which involves the antibodies, which are the primary responders or defenders of your body, and we have a slower response known as the delayed immunity, which involves immune cells that take their time to join the fight against the allergen. Okay, now this is known as allergic conjunctivitis. You have to know that the conjunctiva is 10 times more sensitive than the skin to these allergens. Let us try to classify the types of allergic conjunctivitis. So we have simple allergic conjunctivitis, which is further classified into three categories. Then we have vernal keratoconjunctivitis, known as VKC. We have atopic keratoconjunctivitis, AKC, giant papillary conjunctivitis, abbreviated as GPC, flictenular keratoconjunctivitis, abbreviated as PKC, and contact dermoconjunctivitis, abbreviated as CDC. Alright, now let's try to understand these one by one in very simple terms. So we have the simple allergic conjunctivitis, which is classified into the hay fever type, seasonal, and perennial allergic conjunctivitis. Now this is basically mediated by the IgE antibody, and this is known as the type 1 hypersensitivity reaction. Okay, so it's almost an immediate allergic reaction involving the mast cell degranulation. More about pathophysiology coming soon, right? Now let's talk about VKC. Now VKC, apart from having the type 1 response, it also has type 4 hypersensitivity reaction. That means not just the mast cells with their IgE antibody, but also chronic T cell inflammation is going to have a role in VKC. Similarly, you have atopic keratoconjunctivitis. Now, atopic keratoconjunctivitis is seen mostly in adults who also have atopic dermatitis. Now, this also has both acute and chronic immune mediated mechanisms. That means it's also a mixed type of hypersensitivity that is both type 1 and type 4. Then we have giant papillary conjunctivitis. It is more of a localized allergic response and T cell driven inflammation, usually caused by mechanical irritation. So, there is a localized allergic response to some mechanical factor, either it could be a contact lens or ocular prosthesis. Again, this is type 1 and type 4, both mixed hypersensitivity. Then we have flictenular keratoconjunctivitis. Here you see inflammation or allergic response to the bacterial antigens. These could be TB antigen or staphylococcal protein. So initially the patient is going to have infection with them, and then there's going to be an inflammatory response to these bacterial antigen, and this is going to manifest in the conjunctiva and the cornea, and therefore it is known as flictenular keratoconjunctivitis. Now this one is type 4 delayed hypersensitivity reaction. Then we have contact dermoconjunctivitis. This is mediated T cell mediated delayed immune reaction to allergens, specifically like cosmetics or sometimes even eye drops, and therefore in a way you can also call it as toxic conjunctivitis, right? Again, this one is a type 4 or delayed hypersensitivity reaction. Now, although we talk about the classification and various terminologies, their presentation, there is quite a lot of overlap over here, okay, in terms of presentation. Now, as a matter of fact, allergic conjunctivitis is more of a spectrum, with simple allergic conjunctivitis present on the milder side, VKC present in the middle, and the AKC, that is the atopic keratoconjunctivitis, on the severe side of the spectrum. Now first let's try to discuss about simple allergic conjunctivitis in detail. So what we'll do is, in this video we'll go from the basics of simple allergic conjunctivitis right up to the treatment of simple allergic conjunctivitis. Alright, so what is meant by the simple allergic conjunctivitis? It is basically a very mild, non specific form of allergic conjunctivitis, which is characterized by itching, hyperemia, and very mild papillary response. Now, again, it is IgE mediated type 1 hypersensitivity reaction. That means it is going to be usually acute or subacute. Urticarial reaction means it's usually associated with itching. Alright, now there are three types of simple allergic conjunctivitis that you're going to find in your textbooks. You're basically going to find a term known as the hay fever conjunctivitis. Now, over here, the term hay fever is a misnomer as the disease was originally discovered in people harvesting hay, but there is really no fever associated with it. As a matter of fact, hay fever conjunctivitis is associated with allergic rhinitis, and the common allergens over here will be pollens, grass, or even animal dandruff. Then we have seasonal allergic conjunctivitis and perennial allergic conjunctivitis. Now, seasonal allergic conjunctivitis basically occurs during the specific seasons, typically spring or fall due to the pollen exposure, while the perennial allergic conjunctivitis is something which is a year-round condition triggered by indoor allergens like dust mite and pet dander. Now, over here, you can see that since pollens are produced during particular season, therefore seasonal allergic conjunctivitis is a more common condition, and also it is associated with outdoor pollens. However, the perennial allergic conjunctivitis is present all around the year, and this is less common. It is not as common as seasonal form, and is associated with indoor allergens like house dust and mites. Okay, now let's talk about the pathology. So, the pathological features of simple allergic conjunctivitis include the vascular response, the cellular response, and the conjunctival response. So, vascular response is nothing but it is characterized by a sudden and extreme vasodilatation of the vessels with increased permeability of the vessels. Now, why that happens, we'll talk about that in a while. Okay, so the vessels are going to become dilated, and there's going to be increased extravasation of certain discharge from the vessel that is known as exudate, and then there's going to be cellular response. Now these exudates basically also consist of various inflammatory cells. So you can have eosinophils, you can have plasma cells, and typically what is important over here is the mast cells, because they are the ones who are going to produce these substances which are responsible for the allergic conjunctivitis. Apart from that, you will have response in the conjunctiva. So what will happen? All these exudates, where are they going to go? They're going to go into the conjunctiva, right? So there will be swelling of the conjunctiva, and gradually as the inflammation sets in and as the allergy becomes chronic, there's going to be increased connective tissue formation with mild papillary hyperplasia. Okay, so this was just a brief thing for the undergraduates, what they can actually utilize for writing their theory examinations. Now let's go into the details of all this, and this will be useful for the residents and the postgraduates, or even undergraduates if they are interested in learning about the subject in a little bit more detail. Okay, now our ocular surface, basically, which is the cornea, conjunctiva, the palpebral conjunctiva, this ocular surface is actually considered a relatively large collection window, which is having an area of several hundred square millimeters. And this window allows the entry of allergens into the body. All right, so here the conjunctiva is a highly vascular and immunologically active tissue, and it consists of these mast cells. Okay, so these cells over here are the mast cells, and predominantly it is the MCT phenotype of the mast cells which are located within the vascular stroma of the conjunctiva. Now, in our video on anatomy of conjunctiva, I told you what exactly is stroma and what is meant by substantia propria. So these mast cells are located in the substantia propria of the conjunctiva, and they can actually increase up to 10 times whenever they are exposed to a particular allergen, and later on they are the ones who are responsible for releasing various inflammatory mediators upon activation. Alright, I hope that is clear. So these mast cells are key players in ocular allergic responses. Now, ocular allergy, as I was talking about, it can be immediate response, which is type 1 hypersensitivity, or it could be a late phase allergic response, basically a type 4 cell mediated response. First, we are going to talk about the immediate allergic response or type 1 hypersensitivity. In type 1 hypersensitivity, initially you will have a sensitization phase, then you have a triggering phase, and then there's going to be release of the preformed mediators. So let's talk about it. The initial exposure to an allergen stimulates the B cells to produce the IgE antibodies, which are specific to that allergen. Later on, those IgE antibodies, which are freely floating, okay, which are produced by the B cells, they will come and they will bind to the mast cells. Okay, these IgE will actually bind to the high affinity IgE receptors, which are labeled over here by Fc epsilon Ri on the surface of the mast cells, and as they attach to these high affinity receptors on the mast cell, they're actually priming the mast cells for activation upon subsequent allergen exposure. Okay, so what happens on subsequent allergen exposure is there's going to be a triggering response, or there's going to be a triggering phase, right? So when the allergen re-enters the system, it is now going to bind to these IgE which are present on the surface of the mast cell, and this is going to cause cross-linking of the adjacent IgE and the Fc epsilon Ri complexes, or the receptor and the IgE complexes. They're all going to get cross-linked, and this is going to actually initiate intracellular signaling cascades. Ultimately, what is going to happen, the mast cells are actually they consist of these preformed mediators like histamine, heparin, and proteases within their cytoplasm and within certain specific vesicles. Now they are going to come out to the surface and they will be released into the circulation leading to allergic response in the conjunctiva. So I hope that is clear. So let's talk about this intracellular signaling cascade that happens within the mast cell, right? So because of the cross linking of the IgE and the receptor, the calcium is going to flow within the mast cell, and this increased calcium is going to now allow microtubule assembly, and these microtubules, which are a part of the cytoskeleton of any cell, they facilitate the movement of these granules to the surface of this cell or to the cell membrane, and ultimately there will be a granule release, leading to release of all these important factors which are involved in the allergy, right? On the other hand side, you can see there's also activation of enzymes like the phospholipase A2, and this phospholipase A2 basically ultimately is helping you in the cyclooxygenase and the lipooxygenase pathway, and is actually helping you in the production of prostaglandins and leukotrienes. Now, you might think that the simple allergic response is just a type 1 hypersensitivity reaction, but as I told you, there is a significant overlap, and therefore it's always better to know the entire pathophysiology, because this is going to be quite similar in VKC as well. So when we talk about the vernal keratoconjunctivitis, in that video I will not go into the details of pathophysiology, so it's better you learn it right here right now. All right. Okay, so what are these granules that are released by the mast cells? So the degranulation process will release these preformed mediators, and they are the histamine, proteases, and heparin. Now the histamine basically causes vasodilatation. Remember I told you there's a vascular response in ocular allergy, and therefore this histamine is the one which is responsible for vascular dilatation, and it's also responsible for itching and increased vascular permeability, and therefore when there's increased vascular permeability there is exudation, and exudation is going to cause swelling of the conjunctiva, and that is known as chemosis. Okay, so we'll talk about chemosis in a while. Then we have proteases like tryptase, and they are the ones who are responsible for tissue remodeling and inflammation, and they are the ones which are responsible for formation of all those structural changes which are associated with allergy, like the giant papillae formation or normal papillary response in the conjunctiva. Then we have heparin. Heparin as such is an anticoagulant, but it is also a co-mediator of inflammation, right? Okay, now I told you that there's one response which is quick response or immediate response, and then you have the late phase allergic response. This basically happens because of synthesis of new mediators. I told you that the intracellular cascade, which leads to increase in the calcium and microtubule assembly, is also causing the activation of phospholipase A2, and this leads to the production of prostaglandins and leukotrienes. Now, activation also stimulates the production of new inflammatory molecules. Now, these molecules, whether it is prostaglandins or leukotrienes, ultimately they are going to intensify the inflammation, and they also intensify what is known as T helper cells 2 response. Now, here I would like to tell you one important point here, that we have T helper 1 and T helper 2 response in the body. The T helper 1 is more of a suppressive response. So if we have good amount of Th1 cells, they have a suppressive role in ocular allergy, and they suppress T helper cells too. These T helper cell type 2 are the ones which are responsible in ocular allergy. Okay, and that is the reason why if you see a patient of HIV along with VKC, usually the severity of the ocular allergy in immunodeficient individuals is going to be way more. And why is that? It's because they have this deficient T helper type 1 population, and therefore their T helper 2 response is going to dominate, and therefore they have more allergies, right? Okay, apart from that, there's going to be lots of cytokines which will be released because of the prostaglandins and leukotrienes, specifically IL-4, IL-5 and IL-13, and they are going to further activate other immune cells. They're going to attract the eosinophils, and also they are going to promote the IgE production, and therefore the whole thing is going to be triggered again. So I hope you're understanding how the ocular allergy is basically a vicious cycle. Now it's time for a shout out. In our previous video on exotropia part 4, we asked you what is orientation of the prism and exodeviation when you are carrying out a Krimsky test, and the correct answer of that question was given by Dr. Abhijit Pandey, and the answer was base in prism. So well done, Abhijit. So this delayed response occurs basically 4 to 24 hours after the allergen exposure. And here the inflammatory cell population that you're going to find will be the eosinophils, neutrophils, basophils and the macrophages, right? So they're the ones which will basically lead to chronic inflammation. Now eosinophils are very important, and this is how you actually find eosinophils. Now let me ask you a very typical question, trivia question, I will say. How exactly do you identify eosinophils on a slide? Okay, so you can see over in this slide as well. So I want you to comment specifically on the pathological identification of eosinophils in relation with the nuclear appearance of the eosinophil. Okay, so these eosinophils are very important in allergy because the major basic protein and the eosinophil cationic protein which is released by the eosinophil is actually toxic to the corneal and conjunctival epithelium, and if it is present chronically it can actually lead to changes in the cornea in the form of, you can see, punctate keratopathy, or sometimes on in chronic exposure you will even find certain sort of ulcers developing on the cornea. We'll talk about those inflammatory ulcers in our next video when we talk about the VKC. So in simple allergic conjunctivitis, these findings are rare. Okay. So now the thing is that apart from that, the epithelium of the conjunctiva itself will also produce various chemotactic cytokines like interleukin 8, and they are the ones which are responsible again for attracting various other sorts of eosinophils and lymphocytes, perpetuating the allergic response. This chronic inflammation, chronic allergy will ultimately have long-term consequences. It will cause goblet cell loss, and when there is goblet cell loss, you know what happens. There will be dry eye and ocular surface dysregulation. There can be fibrosis also. Now this fibrosis is something that you see more in severe cases of ocular allergy, and we know on the severe end of the spectrum we have atopic and vernal keratoconjunctivitis. Okay, and this fibrosis sometimes can even lead to symblepharon formation, corneal scarring, and ongoing inflammation can also result in corneal neovascularization and vision impairment. So here, let me tell you that we are talking about the pathophysiology of ocular allergy in general. But from now onwards, what I'm going to be discussing is I will be discussing the simple allergic conjunctivitis. Now, simple allergic conjunctivitis mostly is acute and subacute, and you will not find all these changes that we discussed here, the goblet cell loss, the fibrosis, and stuff like that in simple allergic conjunctivitis. Okay, so this will occur in AKC and VKC and stuff like that. All right, now let's talk about the clinical picture. And here, let's now stick to the simple allergic conjunctivitis. So let's discuss about the clinical picture of seasonal allergic conjunctivitis and perennial allergic conjunctivitis. Now, usually the patient will complain of intense itching. The pathognomic symptom of ocular allergy is actually itching. Without itching, a condition should not be considered ocular allergy. Apart from that, they will have burning sensation in the eyes, they might have watery discharge, and they can also complain of mild photophobia. Coming to the signs, what we elicit on a patient. So, usually there will be vasodilatation in the conjunctiva. We already discussed that in the pathophysiology, and therefore, you are going to see the redness in the eye in the conjunctiva, and that is known as hyperemia. Apart from that, you're going to see the swollen appearance of the conjunctiva. You can see over here, you can see this reflexes. This basically indicates that there is fluid beneath the conjunctiva or in the subconjunctival space. And this is basically because of the exudation that was occurring because of vasodilatation. And this ballooning or swelling of the conjunctiva is known as the chemosis. Now, sometimes what happens is that when patients rub their eyes, the chemosis can become more dramatic with significant ballooning of the conjunctiva also. So over here you can see this ballooning of the conjunctiva, and sometimes this chemosis can actually extend beyond the eyelid as well, right? So that's also a severe type of chemosis. Apart from that, you can have mild papillary reaction in the conjunctiva. So you don't really see those cobblestone appearance that is associated with VKC, and you won't see the giant papillary reaction that you see in GPC, right? So over here in simple allergic conjunctivitis, basically the patient will have a very mild papillary reaction. Now, if you don't know what exactly is meant by papillae, what exactly is a follicle, I would like you to visit our basic video on conjunctivitis where we discussed on the pathophysiology of a follicle and the papillae, and what are the various differential diagnoses that you have to think about when you see papillae in an eye. Alright, apart from that, you can have edematous eyelids. This is more so common in case of an atopic keratoconjunctivitis, but it can occur in case of allergic conjunctivitis as well, more so because of the constant rubbing of the eyelids. Then we can have discharge. Discharge could be serous, rarely it could be mucopurulent as well, but a clear ropey discharge is something which is characteristic of ocular allergy. Associated symptoms, the patient can have seasonal rhinitis, the patient can have pharyngeal symptoms. Why? Because most of these patients will also have systemic allergy, right? And therefore these seasonal rhinitis, pharyngeal symptoms are quite associated factors along with even asthma. All right. So when I told you about perennial allergic conjunctivitis, I told you that's usually associated with indoor allergens like animal dander, dust mites, feathers, even mold on the walls, spores, fungi. Both home and occupational exposure should be evaluated in these patients. Now, often parents have misconceptions saying that their kid doesn't really doesn't go outdoors and still they are suffering from allergy. So in those patients, you can explain them that even indoor allergens could be responsible for the perennial allergic conjunctivitis. All right. When we talk about the clinical picture of perennial allergic conjunctivitis, it's quite similar to seasonal allergic conjunctivitis. It's just that the symptoms will persist throughout the year with no clear time of onset and no clear sign of termination. So you will have the conjunctival hyperemia. However, the conjunctival hyperemia that you see in a perennial case is going to be milder compared to what you see in a seasonal allergic conjunctivitis. The chemosis is going to be variable. Sometimes you might have a severe case of chemosis, which will result in lower lid swelling as well. And sometimes you can have this ballooning of the conjunctiva that you see over here. And at times, because of the severe ballooning of the conjunctiva, the tear film will not be able to really hydrate the cornea beneath that area of the balloon conjunctiva or chemosis, and that could lead to a possible Delin. A Delin is basically a localized area of corneal thinning due to a dryness spell, right? So let me give you a few examples over here. Now, this is quite rare in allergic conjunctivitis because chemosis usually responds very well to your treatment, right? So if someone has a chronic chemosis which is neglected and it's present near the limbus, so that limbal area might not receive adequate amount of corneal hydration, right? So over here you can see this area right? On fluorescent angiography, you can actually see this pooling of the fluorescent, indicating that there is some sort of depression over here, right? So this is known as Delin. Now, Delin is produced when the corneal stroma loses an excessive amount of water, and this loss of water can lead to stromal dehydration, and ultimately there will be thinning of the stroma. Now, this loss of water is caused by improper wetting of the corneal surface by tear film, and this poor wetting is usually caused by an elevated mass. So, it need not be always chemosis. Sometimes you could have a mass growing over here, which is preventing the adequate wetting of the corneal limbus or the cornea over here, leading to thinning of the cornea, and that is known as the corneal Delin, right? So, this is an example of the corneal Delin. In the first picture, you can see diffuse elimination for the initial assessment. So always use a diffuse elimination in the initial assessment, and then you can use a narrow slit beam to basically evaluate the area of corneal depression. I'll show you the picture in a while. And over here you can see Delin, which is outlined by fluorescent, and then you can see this pooling over here. And again, this is an ASOCT picture. You can see this depression in the conjunctiva. Okay, yeah, so this is what I was talking about. So use initially a diffuse elimination, then use a thin slit beam. You can see this depression here in the beam that indicates that there is an area of thinning in the cornea. Alright, so you will also have papillary reaction. Really don't have a good picture of papillary, but you can see this mild dot-like structures here in the tarsal conjunctiva, which basically are papillae. So you can do a staining of the papillae and look for the stain, for the uptake of the stain. If the stain is too much, like seen in here, it basically indicates severe papillary response. So mild papillary reaction usually will not take staining, but a severe papillary response papillae will basically take up the staining, basically indicating that there is more damage to the ocular surface. All right. Now, associated conditions, as I told you already, perennial rhinitis is more common with perennial allergic conjunctivitis, and its nasal and pulmonary symptoms like asthma can coexist due to shared allergen triggers here. Now, the question is, how do we go about diagnosing a case of simple allergic conjunctivitis? It's very easy. Okay, so it's usually the history which gives away the diagnosis. So, over here, the patient will have intense itching. However, you have to know about various other differential diagnoses of itching. So, itching could be because of dry eye, toxic conjunctivitis, contact dermatitis, and even blepharitis. So, important over here is to understand the location of the itching. This distinguishes basically whether you are dealing with a conjunctival itching, which occurs in case of allergic conjunctivitis, or you are dealing with some other cause. So, usually in case of blepharitis, the patient is going to rub the eyelids, right? And usually the patients are going to use their index finger and move it in the horizontal way. However, when we talk about the allergic conjunctivitis, usually it is the bulbar conjunctiva which is itchy, and therefore they're usually going to use the palm of their hand to rub their eyes. And kids, when you observe them, they'll be using their knuckles to rub their eyes. In case of dry eye, usually the itching is along the nasal inner bulbar conjunctiva, because they have this allergen accumulation near the tear drainage area. Toxic conjunctivitis, usually you will have a history of exposure to some drug, and usually it will be the inferior part of the conjunctiva which will show all the redness and all, right? So I hope that is clear. So itching is a very important finding in a case of ocular allergy or simple allergic conjunctivitis. However, sometimes if you are still not sure, you can actually do a superficial conjunctival scraping, or you can observe, in simple terms, the discharge that comes out of the patient's eye beneath a microscope, and you will observe these eosinophils. So eosinophils are really specific for allergy. So you can have these eosinophils like you see over here. This is one eosinophil here, and again this one is an eosinophil. Let me just use my, yeah, so you can see over here, this is an eosinophil, this is an eosinophil. Okay, apart from that, you can actually diagnose the allergy based on allergen specific IgE. Now, allergen challenge testing and skin testing is something which is rarely necessary. It basically involves exposing the skin to small amounts of suspected allergens and then observing the reaction. So, this test could be done either as a patch test or a prick test or an intradermal test. So basically in your prick test, basically a small drop of allergen extract is placed on the skin, and then you're going to prick that area, or slightly rub that area. In a patch test, you take a patch with the allergen and put it on the patient's skin. An intradermal test will be something where you are injecting the allergen into the skin, and then you are seeing for an allergic response, right? So these tests are very rarely done for simple allergic conjunctivitis. Now let's talk about the treatment of simple allergic conjunctivitis. The first thing would be to identify the allergen and avoid the allergen. So you can advise the patient to stay indoors during the seasonal exacerbation of the pollens. Okay, so whenever the patient will usually be aware of the seasons when he has these exacerbating episodes of seasonal allergic conjunctivitis, you can advise them to stay indoors. Then you can advise them to use certain air conditioners, and if it's affordable, they can use air filters. They can keep their windows closed. They have to wash their hair and clothes after any outdoor exposure. And for perennial allergens, they can cover the bedding with plastic covers. They have to remove the carpets, maybe avoid pets in the bedroom as well. Certain behavioral modifications that can be used in case of allergic conjunctivitis could be the patient has to avoid rubbing their eyes. So because this prevents an itch rub cycle. So what happens is that if they rub the eyes, the mast cells, because of mechanical stimulation, also they will release the histamine. Again, there will be intensified itching, and again the patient is going to rub, and this itch rub cycle will keep on continuing. Okay, however, it is easier to advise this, but it's difficult for the patient to follow. Okay, another thing that could be done is application of cool artificial tears to dilute the allergens. So definitely your lubricants, your artificial tears have a role in allergy because they will dilute the allergens. You can advise the patient to use cold compresses, and this basically not just reduces the swelling, it has also been shown that it reduces the release of the inflammatory mediators within the eye. Okay, so these are behavioral modification, that is avoid eye rubbing, and certain other alternative way of treating the patients. So I hope you understood the pathophysiology of ocular allergy. Now if you would have understood that, understanding the medical therapy will become really easy. So now the first agents over here are the dual action antihistamine and mast cell stabilizers. Okay, now example of this is olopatadine, ketotifen, and epinastin. Okay, the advantage of using these therapeutic molecule is the rapidity of symptomatic relief, which is given by immediate histamine receptor antagonism. Now the thing is that we know histamines are the ones which are responsible for allergy, so we give them antihistamine. And mast cells membrane is something which keeps on rupturing and releasing all those preformed mediators, so we give them something to stabilize those membranes. These are known as mast cell stabilizers. Now there are certain drugs like olopatadine, ketotifen, epinastin. These are the ones which actually have a dual action. That means they both act as antihistamines and mast cell stabilizers. So dual action drugs are the first class. The second class of drugs are the antihistamine drugs. So here we have alcaftadine 0.25%, bipotastin, levocabastin, imidastin. Okay. Then we have the third category, which are the mast cell stabilizers. So we know that the mast cells were basically releasing those preformed mediators, and therefore if we have drugs which will stabilize the membrane of the mast cell, we can actually prevent ocular allergy. And therefore mast cell stabilizers are used as maintenance dose and also as a preventive measure in patients with seasonal and perennial allergic conjunctivitis. Specifically in seasonal allergic conjunctivitis, you can also start these drugs 2 weeks before the allergy season. Then we have NSAIDs like ketorolac, tromethamine. They basically reduce the prostaglandin concentration and therefore reduce the prostaglandin associated itching. However, there's a stinging sensation in the patient eye after the installation of this drop, and that is the reason why it is not commonly used. The other class of drugs are the decongestants. These are basically nafazoline. They also have some antihistamine effect. Now, they basically reduce the symptoms of vasodilation by causing vasoconstriction. They are basically sympathomimetics, and therefore they stimulate the alpha receptor, leading to vasoconstriction, and therefore they prevent they basically deal with hyperemia. The problem with decongestants is that they are very, very short acting. They usually last for the effect just lasts for about 2 hours maybe, and then they cause rebound hyperemia and tachyphylaxis. So tachyphylaxis is a rapid decrease in the efficacy of a drug when it is repeatedly used over a period of time. Now, due to these two issues, one is rebound hyperemia, the other one is tachyphylaxis, nafazolin and other ocular decongestants, they are not recommended for long-term usage. Okay, next class we have is the corticosteroids. They basically include the loteprednol and the fluoromethalone over here. Now, both are quite similar in terms of efficacy and the risk of raising intraocular pressure. However, the advantage of loteprednol is that it allows for some titration as it is available in concentrations of 0.1%, 0.5%, and 1%, if I'm not mistaken. Now, this flexibility is not available with the fluoromethalone. That said, corticosteroids are not used in all patients. They are reserved for severe cases and should be administered at the lowest effective dose with the lowest possible concentration and for the shortest duration. This is because there are a lot of risks which are associated with corticosteroids. Patients can get cataracts, IOP elevation, glaucoma, they can be steroid responders, and also susceptibility to infection. Whenever you see a myopic patient, whenever you have young patients, whenever you have a glaucomatic patient, you have to be really be on your guard regarding these side effects of corticosteroids and reserve them for severe cases. However, in some cases with severe allergic symptoms like severe itching, you might have to start corticosteroid, and in those cases, you start them on a short dosage, on a shorter duration, on the lowest concentration, and then you substitute as the itching stops. You can basically switch on to other classes of the drugs. Okay, now sometimes systemic treatments might be given like oral antihistamines. Now these would be given for those patients who will have some other symptoms as well, like chronic rhinitis and even asthma. Okay, the only thing with oral antihistamine is that they might actually worsen your dry eye symptoms, because oral antihistamines also have some sort of anticholinergic effect that can lead to worsening of the dry eye symptoms. Alright, now the treatment choice basically depends on the severity, symptom profile, and duration of the allergies, right? Now, if you're an undergraduate or a beginner, it's enough if you know the classes of the drug, right? However, if you're a postgraduate, you should know when to start what drug. So, in mild cases, if the patient has very mild symptoms, so you will go ahead and start them on the over the counter decongestants. These would be your nafazolin and antihistamines. Use them for short term because there's a risk for hyperemia and tachyphylaxis. Apart from that, you will start them on artificial tears because you have to flush out the allergens and inflammatory mediators. With moderate allergic symptoms, you can start them on topical antihistamines like levocabastin, amidastin. This will reduce the itching and redness for short duration. The thing is, the problem with antihistamine is that they act for short time and you need frequent dosing, like 4 times or 5 times in a day. Apart from that, you can start them on dual action agents like the ketotifen, olopat, and epinastin. Now, olopat is something which is frequently used. It has this once daily dosing. For severe cases where you have severe symptoms, severe papillary reaction, you can start them on topical corticosteroids like lotipred. Use the lowest concentration for the shortest duration. NSAIDs, I don't think so anyone is using them, but it is still used in some practices. The problem is the stinging. However, some report says that the itching is actually controlled very well with ketorolac. So if your patient is able to tolerate, maybe you can start them on NSAIDs. Apart from that, oral antihistamines will be used only if the patient has systemic allergic symptoms, and you have to use them with caution about worsening of the dry eye symptoms. Now, if the patient has chronic symptoms or recurrent symptoms of seasonal allergy or perennial allergy, in those cases, you will give them mast cell stabilizers, specifically when the allergic season is about to start. Management of SSC and PAC is basically a step ladder approach. It varies from one practice to another practice. Now, sometimes I don't think so. It is rarely needed in case of simple allergic conjunctivitis, but just for the sake of completion, this will help you to remember the treatment for VKC as well. Some people can use topical calcineurin inhibitors. They are basically immunomodulatory drugs to be used in those patients where you can't use your steroids. Maybe the patient is a steroid responder. Like for those severe cases of allergy, you can use cyclosporin A and tacrolimus. Tacrolimus is basically available as a 0.3% eye ointment. You can actually apply it on top of the lid to avoid the direct contact with the conjunctiva because it's toxic. So usually tacrolimus is used as a maintenance drug in these patients. Now you can see something in selected case patients you can try immunotherapy. I don't think so this is used so often in case of simple allergic conjunctivitis, but let me tell you what exactly is immunotherapy. Immunotherapy basically involves gradual introduction of the allergen to the patient, typically through skin, and so that is called subcutaneous immunotherapy, as a way it's also known as SCIT or allergy shots. Then you have sublingual immunotherapy also, where you put the allergen in the form of tablets or drops under the tongue. So basically, you're gradually introducing the allergen to the patient, typically through skin or the sublingual route, and you're building up their immune response and you're reducing their sensitivity to that allergen over time, right? So that is known as immunotherapy, reserved for very selected cases. Okay, so that was regarding the basics to advance of simple allergic conjunctivitis. Do give your feedback if you like the video. That's all for today. Thank you and have a nice day.